I'm Saye Khoo. I'm an ID physician and a clinical pharmacologist, and work with David Back, who many of you will know, and together with Fiona and many other people, run the Liverpool website. So let me move on. So the Liverpool Drug Interactions group is not just a Liverpool outfit. We have pharmacologists from Glasgow, we have pharmacologists from Basel, um, and we have friends around the world. And our mission, when we started out in 1998, was to promote safe and effective prescribing by giving free was important, comprehensive, up-to-date, and evidence-based information on how to manage drug interactions. And now education is added on as another key aim to try and help improve the quality of prescribing as well, when the quantity of prescribing is clearly going up. So the Liverpool drug, how many people here have used the Liverpool website? Anyone? So about maybe 25%, and most people haven't. So it may, and it may be that the language is an issue, and I understand that, and we are sorry that it's not more widely available. But if you go to the URL drug interactions or hiv-druginteractions.org, you can look at the HIV drug interactions. We have a hepatitis, we have an oncology drug interactions with a lot of the new targeted agents. And there are many things. There are prescribing resources, which I'll talk about in a minute. But the main reason why people go there is to look at the drug interactions checker. And the checker is a tool where if you click on the checker, you get a choice. You choose your HIV drug first. So you can search your, and it could be, you can see down here, darunavir cobicistat has been chosen, because you might think about that. And then you choose your co-medication, and you can see down here that, wow, what a dot. Clopidogrel and dabigatran. So there's someone obviously having a darunavir cobicistat, and then has a pulmonary embolus or something like that, and needs additional treatment. And then you get an interaction, and the interaction is a traffic light. So it's red for don't give, green for do give, yellow is you can give. Treat it like a green, because the label sometimes says that there's a theoretical interaction, but really in practice it doesn't matter. Okay, so yellow and green are the same thing in terms of clinical action. Then there's amber or orange. Orange is the difficult one. Okay, orange does not mean you cannot give. It means that you might give, but you might have to do something. You might either have to be more aware of drug interactions, look out for toxicities, monitor liver function or monitor renal function or something, or else change the dose. So the orange you have to read, okay? So orange does not mean you cannot give. That's important. So it's like driving a car. We are having this discussion. Everyone knows what to do when the traffic light is green and when it's red. So what do you do with an orange traffic light? Who drives faster? Actually, I do, actually, so I have to. Okay, so many people do, but it depends. You have to make a judgment. So when you see the traffic light going amber, you have to make a judgment, and it's exactly the same with that. You have to make a judgment. So it will tell you that you can't give darunavir, cobicistat, clopidogrel, and it'll tell you why. There's a very quick summary, and then there's a big long detail for you, but the summary is quite short, so you can read it quickly. And it also tells you, we also tell you what the quality of evidence is. Is it low because we don't know the answer, but we guess the answer, or is it high because there's an actual study with proper clinical data? So we give you a recommendation, a strength of recommendation, and we give you a quality of data upon which that recommendation was made. Now, if it's all red and a person has got to be on darunavir, what do you do? So we have a button now that says look for alternatives down here. Okay, and if you pick that, oh, I'm pointing the wrong way. Okay, if you look for alternatives, it will tell you about all the antiplatelet agents and all the anticoagulants and which ones you can choose. Okay, so this is a new addition that helps you to choose the best treatment for that patient. Yeah, and I should say you can download these reports as a PDF and put them into patient notes as well. Okay, right. There is a easier and quicker way for me, which is to use a smartphone. So if you have poor internet connection, if your hospital has computer equipment as slow and outdated as ours, You might find it quicker to use a phone, which was the app that I showed you at the start. And if you want to download that, you can pick your HIV drug, pick your COMED, and pick your and get your results. On the website, not the phone, on the website, going back to the URL, we have other things as well, in addition to the checker. So we have advice sheets, and you can print these out. These are made so that you can print them on A4 or A3 and stick them on your clinic wall. And those of you who want to translate it into your language, please do. Just let us know, and maybe we can use that for other people. And so if you've got someone on boosted PIs and they have to have the asthma treatment with steroids, and we know about the difficulties and the risk of steroids, you can print out a chart and choose the best steroid, inhaled steroid, for your patient. Again, which is what that is. You can choose the best painkiller, antidepressants. We've got a lot of resources. So if your patient is on efavirenz, you can choose what, and we have that for contraceptives as well. Okay, so there's plenty. Oh, here we go. Contraceptives. So it tells you, and you can put them on your clinic wall if you don't have internet connection, and that's quite helpful. We also have, so those are risky drug combinations. We have risky clinical situations also. So people on intensive care units, prescribing the elderly. So we again have we have helpful sheets that can be printed out. And these are, for example, hormone use of hormones for gender transitioning, now becoming quite a problem in many parts of the world. This is one of the most useful things and one of the most used things on our website. Which formulations can you crush? Which ones are in syrup? Which ones you cannot crush in people who cannot swallow? So people with pill phobias, perioperative intensive care patients. How do you get drugs into people when they are unconscious or cannot swallow? Okay, so there's a whole range of what you can do. Okay, and some of this is based on what the data sheets are, but a lot of these are not to be found in the data sheets on the drugs. Okay, and then we have PrEP. We have information around PrEP as well to help people manage these kind of clinics. So a quick summary of the website. It's used widely, so around 188 countries have use it. In the last year, there were 4 million drug interactions downloaded, so it's quite a lot. It increases every year, so every year 20% more people use it than the previous year. In the UK, it is the UK standard, so Department of Health say that every GP letter in the UK must carry our URL. That's because the worry about GP prescribing and a lot of interactions that are not detected because they're not known by the hospital. It's recommended in many international and national guidelines, and more recently the website is used for electronic prescribing. So that's examples of that as far away as Uganda and Australia, and there's been a translation into Japanese for the hepatitis website since 2017. Spanish translation expected to launch later this year in December. Is that right, David? Yep. Okay. On World AIDS Day, we hope. And of course, some of you will be saying, well, why isn't there a Russian one? Well, we'll be very happy to hear from you and to discuss that. Okay, so these are just showing the increased usage year on year in the hepatitis and HIV websites. I'm not going to go into that. It's used for it's quite influential, and it's been great for us to get feedback. So we've had feedback from the current chair of the British HIV Association, one of the most useful tools in HIV patient care, widely trusted. Trust is a big issue here, actually. We're sponsored by pharma, but the editorial content is independent and it's international and it's overseen by an editorial board. EASL, it's a major influence on HIV treatment practices. There's trust again for the British liver. WHO, it's a world-leading resource used to develop global guidelines. We reproduce the information on our guidelines. So I hope that this shows that we are trusted, but we don't take that for granted. We work very hard, and there are numerous arguments that we have about how we quality control these things to make sure that we give the right advice. And that's been acknowledged in some outputs. So I'm just going to finish off quickly by telling you a little bit about the epidemiology and why drug interactions are still a problem. So if you look, so actually we're clinicians, right? At least 2/3 of us are, and we we are not interested in drug interaction. We're interested in harms. Okay, we know the benefits of treatment, and what we don't want to do is to harm patients. And a lot of these harms pass unnoticed. So if you look at the evidence, what is the evidence that drug interactions cause harm? So not all drug interactions will cause harm. If it's red, it's contraindicated. The label says you must not give it. If it's amber, you have to make that call, and we'll talk about that later. But if you look at the presence of red or amber interactions, do people do worse on them? And the evidence is pretty strong that actually harms develop. So this is the US Veterans Affairs cohort, and this is a 9,500 HIV positive people compared with HIV negative controls. And if you look at people taking polypharmacy, so not drug interactions, there is drug interactions coming out next year, but polypharmacy is associated. The more drugs you are with HIV, the more likely you are to be hospitalized and to die. Now, of course, part of that may be to do with the disease. The more diseases you are, the most likely you are to die. And it may be nothing to do with the number of drugs that you are taking. These are data from Giovanni Goraldi from the Modena, the GEPO cohort. This is about 3,500 patients. And he looked at, he used a frailty tool, and he counted the number of medications. And the bottom line is this is the graph that you should look at. This is for mortality. These are the risks of dying. If you have very few drugs and you're frail or not frail, you do very well. If you are polypharmacy and you're not frail, you're mobile, you do just as well. If you're polypharmacy and you're frail, so you've got markers of frailty, that's to do with sarcopenia, all right, impaired muscle function and functional status. If you're polypharmacy and you are frail, you are significantly more likely to die, okay? And that's a sign that actually there are drug interactions that are adversely affecting people because of high anticholinergic burden, because of sedative, because of a lot of other drug interactions as well. This is a large cohort in the UK of people. So it's 1,000 people with HIV. Most of which, 2/3 of which are over the age of 50, and about 1/3 are controls who are under the age of 50 years. And this data has been described already and led by Alan Winston. And basically, when you collect all the multiple morbidities, so we know our cohorts are getting older and they're picking up more medical conditions. And if you count them, it's not randomly distributed. The multi-morbid conditions are clustered in people. And we know that, don't we? So it's not like, you spread it evenly across the population. Some people get clusters of disease. And so there's a mental health cluster. So people with depression, sleeping disorders, anxiety, and panic attacks, okay? There is a cluster of sexually transmitted disease, hepatitis C, gonorrhea, chlamydia, syphilis. There are two clusters that overlap. So there's a cardiovascular cluster of angina, heart failure, hypertension, MI, and coronary artery bypass. There's another cluster which is metabolic. So type 2 diabetes, lipodystrophy, dyslipidemia. Yeah. And these, again, and that's our clinical experience. Now, in the non-HIV geriatric literature, there is plenty of evidence, and these same clusters, apart from the sexually transmitted disease, you find these same clusters, and you will find that same overlap between the metabolic and cardiovascular clusters. So this is what happens in real life. Yep. So what we did, and this is the next slide shows some unpublished data, which will be shown in EX next month, but is that we took all these sleeping problems, anxiety, panic attacks in these mental health problems, and we looked at all the drugs in that class, and we looked at the risk of having a drug interaction with HIV drugs. Likewise, we took the cardiovascular cluster with all these different conditions, and we took the metabolic cluster with diabetes, dyslipidemia, hypertension, and we did that. And there's some interesting data that come out of this. So if you look at mental health cluster or the cardiovascular cluster or the metabolic cluster, okay, the group of comorbidities, and you look at boosted regimens, PI or elbitergovir, you find that it's about 50% risk. There's going to be a 50% chance of an amber or a red, okay? But these are old regimens. What about new regimens? Well, if you look at new regimens, here we go. It's virtually gone. So, Eviplera down here, rilpivirine, mainly PPIs. But if you look at the newer integrases or doravirine, it's all very low. And the interesting thing here is that 2-drug regimens don't really improve that, okay? So by all means, choose 2-drug regimens, but the DDIs, but DDIs, avoiding DDIs is not really a reason for choosing 2-drug regimens in today's modern regimens where all the regimens are pretty clean anyway, okay? So this slide shows you the relative risk of regimens, modern regimens for drug interactions, DDIs. Okay, so the relative risk has fallen. But so does that mean that DDI is not a problem? The evidence is that the absolute risk, how much DDIs actually occurs, the absolute risk has not changed. Okay, and that's really interesting. So let me just go through this slide. These are big cohorts of DDI. So this small size is n equals about 100. This red one here is about 1,000. These kind of size is about 9,000, about 4,500. That size is about 9,000, and the biggest one is 23,000 patients. So the HIV positive patients, these are big cohorts. All right. The denominators are different. So some of the denominators are HIV patients taking HIV drugs, but some of them are hospital-based and some of them are community-based, so they also capture what the people are getting from their GPs. The numerators are slightly different. All of these, except for 3, use the Liverpool tool. And then the colors here, the amber is Europe, the blue is Sub-Saharan Africa, and the red is America. Okay? And you can see that the rate of drug interactions, clinically significant, so that's amber or red, is about 30 to 40%. And even in 2019, there's a big spread. Okay, so the absolute risk has not dropped. And the reason is that we got many older people with many more diseases, and we're giving more drugs per disease. So now we're giving dual platelets, we're giving ACE inhibitors, statins for an expanded range of indications. Okay, the other interesting thing here is that in 2019, your risk of drug interactions seems to depend on how much integrases you use. So if you use very low number of integrases, so the Barcelona cohort, 14.5%, has got a higher rate of drug interactions, whereas cohorts that use a lot of integrases, 50% or more in some cases, have the lowest frequency of drug interactions. Yep. Okay. And the last thing I would take from this is it's all the same culprits. Steroids always appear top. Steroids, statins, quetiapine, and PPIs. They are, and amlodipine. They're always, whichever country you go, they're always somewhere in the top. Okay. So this is one. This is one study. The largest of the studies, 23,000 HIV positive people. Oops. Let me just go back. 23,000 HIV positive patients from Madrid. This is a community-based survey. And you can see, again, 6.5 million HIV negatives, which is in green. And you can see that really at every age group, until you get to the extremely old, there is HIV positive patients are more likely to have polypharmacy. That's excluding HIV drugs, so 5 drugs or more excluding HIV drugs. And that drug interactions are common. And frighteningly, so there's 3% of people in Madrid with HIV are walking around with red interactions that say do not give, contraindicated. Okay, and half of these, 375 people, are on steroids. So that's the biggest group. And it's not because the physicians don't know that steroids can't be given with boosted protease inhibitors or elbitergovir. It's just that the physicians, the HIV physicians, don't know that these patients are taking steroids because they're inhaled steroids or injections for joint pain or nerve root pain. So someone else is giving them steroids. So there are 400 people in Madrid with hips waiting to fall to pieces. Yeah, okay, and that's a serious problem. In 2019, that's a serious problem. And you would have thought we should know how to manage them. So let's go back, and I'll finish off now. So I said that there was green and yellow, so that's fine. It's an advantage to give the patient. So you're weighing risk and benefit. It's definitely benefit. Give it. Okay. Red is easy. Don't give. Okay. And as I say, the ambers are the difficult ones. It's a difficult call to make. And so I'll finish by saying, if you see an amber, it does not mean you can't give it, because there's a specific reason why we call it amber. Because if you read an amber as mustn't give, you close the door for your patient, and there are some important treatments that you're going to deny them if you don't read the words in that amber recommendation. So amber means that there is some benefit, but there's also some risk, and you have to weigh. And that weighing of risk and benefit is an individual. That patient in front of you, what is his risk or her risk? What is her benefits? And so you will have you have a lot of people like Amber, but if you look at them, okay, some of them it's okay, but some people you say no. So if there's a drug interaction that increases your transaminases, and you've got someone who already got cirrhosis, you'd be worried about that, wouldn't you? Or someone who can affect your kidneys. So a drug interaction that raises levels of tenofovir, and you've already got EGFR of 50, you'd be much more worried. But if you've got an EGFR of 90, you might say, okay, that's fine. If you've got an EGFR that's borderline 61, you say, okay, I'll give it, but I'll check the EGFR a bit more often. Okay, so this is a measure of clinical judgment. One thing that's become a big issue now is how we manage comorbidities. So people are not dying of HIV; they're dying of their comorbidities. Yeah, and because we are worried about the comorbidities, we're not treating them. We're worried about the drug interactions. We're not treating the comorbidities properly. So there's evidence from Chelsea and Westminster Hospital that patients, particularly those on boosted PIs, are getting the wrong statins, and their lipids, or the wrong doses of statin, and their lipids are not controlled. So we treat their HIV, there's no drug interaction, but they die of a heart attack. Yeah. There's data from Italy looking at antidepressant levels, and HIV positive patients on boosted PIs have very low levels, and that's because people give tiny doses of antidepressants and they never titrate up. They start low and they never titrate up to get the patient better. So so we can. Education is important, but sometimes we need to think about other things. So so I put this together because just before I got on the plane, and this is a patient I saw last week, and this is a man with he's a man with treatment experience, and he's got a little bit of baseline resistance. Okay, he's got a little bit of, so he's on a boosted regimen, and this is an old regimen of you remember the Duet study, so boosted darunavir, etravirine, and Descovy. He's got a borderline kidney function. One day it's green, the other day it's white, but sometimes it's generally low. It's borderline low. He's got a bit of diabetes, and he's got severe peripheral vascular disease, 2 femoral popliteal bypasses. The surgeons say, I have done everything for you. The next step is to take your leg off. So there's nothing more to do with this man but to amputate his leg for pain relief. Okay, so. And so he's got so let me just move this. So here's his, for 10 years, since 2009, he has not had his cholesterol controlled, and his blood pressure has been systolic 160 to 180, 90 to 125. So for 10 years, we have avoided a drug interaction, but this man's blood pressure has never been controlled. This man's lipids has never been controlled. Okay, now as physicians, his HIV physicians were worried about this resistance. Uh, if you ask the man, what is he worried about? He's worried about whether he's got a leg to stand on tomorrow. Okay, so there is an issue here. Yeah, we say if there's some resistance, particularly two-class resistance, you have to give a PI. Yeah, you can't rely on it integrates. I think data may be changing, but that's not an unreasonable view to hold. But because we hold that view, um, the end result is that we have treated it badly. So we treat metformin badly because we don't want to give dolutegravir because there's an interaction. We're worried about ritonavir and cobicistat and dabigatran. We give a lousy statin. So pravastatin is not as effective as rosuvastatin, atorvastatin, or pitavastatin for high-risk coronary and peripheral vascular disease. We know that. So there are potent statins. And then is amlodipine. We go up to a sort of a treatment dose, but we don't go up to the top of the dose because we're frightened of effects. So we've undertreated this. So you got two choices. You could increase education and try and manage these difficult cases, or you could preemptively switch, which is what I did to this man. I could say, look, let's get him off these things and put him on integrators, and then you don't have to worry about this, and then let's save his leg. And if we get 2 more years out of his leg, well, that's 2 more years of good life left to this man, and I think that's worth doing. So I'm going to conclude now, and with exactly what I said. The absolute risk of drug interactions is still high. We know all the common culprits, and I've listed them here, and that we should maybe think about some switches so that people like me have no job to come back to. That would be a good thing. And I will finish by thanking all my collaborators, particularly Fiona, whom you'll hear from, and David Back, who's standing at the back as one of the original architects of the Liverpool website. Thank you very much.